Hi, I'm Dr. Gary Hoffman. I'm the founder of the Center for Vasculitis Care and Research at the Cleveland Clinic, former chairman of the Department of Rheumatic and Immunologic Diseases, and a professor of medicine at the Lerner College of Medicine. And we're here today to discuss vasculitis, and particularly now to discuss a disease that we call granulomatosis with polyangiitis that was formerly known as Wegener's granulomatosis. And we're very grateful to Don Medaglia for coming in to discuss his experience with what we'll call Wegener's, or GPA, granulomatosis with polyangiitis, because he's a real veteran of this disease, having had it for many years, and can share with us much of the triumphs and also some of the not such triumphant experiences with GPA. Let me start by just telling you a little bit about this disease, because it's very gratifying to know from where we've come. So where did we come in the period before 1960? If you had a diagnosis of GPA, Wegener's, before 1960, your average survival time was about 5 months. If you looked at patients who had been diagnosed a year prior, this is in the era before 1960, 80% of patients were dead within a year. So if you followed a lot of patients with this disease, and nobody did because it's quite rare, but you're in the business of doing body counts. And why was that? It was in part because this disease is particularly nasty. It affects small and medium-sized blood vessels in critical organs, such as the upper airway, including the sinuses, ears, the trachea, the main air tube going to the lungs. It affects the lungs also, so the lower airway, and the kidneys. Now, while that's the classic signature of GPA Wegener's, any organ in the body can be affected. So now we're talking about critical organs, and it's easy to see when you don't have effective therapy, as in prior to the 1960s, people died in a wholesale type fashion. In the 1960s, we began to see in the literature a lot more written about the use of prednisone and high-dose steroids with this disease. And what do you know? It actually, by itself, high-dose steroids did not save lives, but it produced a lot of side effects. It was in the era around 1970 when Anthony Fauci at the National Institutes of Health introduced prospective studies using cyclophosphamide, also known as Cytoxan, in conjunction with prednisone, that he had an experience that he never ever dreamed of. People got dramatically better. Not only better, but they went into remission, meaning no signs and symptoms of active disease. And people who looked like they previously would have died were now surviving. And the story evolved to a point where I became involved with it when I was at the National Institutes of Health from 1986 to 1992, where we were seeing much more side effects from Cytoxan than we were really comfortable with when we were using Cytoxan for many, many years in a patient to keep them in remission. And so we started a program back then of alternative therapies to cyclophosphamide, using medications such as methotrexate and subsequently other medications to see if we could go from chronic cyclophosphamide use to stepping down after a few months to using a drug like methotrexate. And subsequently other people did the same kind of step-down studies to azathioprine, and then later mycophenolate mofetil, also called Celcept, also called MMF. All of them worked, and all of them didn't have the long-term toxicity of cyclophosphamide, which includes a lot of things, like burning the bladder, causing bladder cancer, increasing the risk of a number of malignancies, shutting down the bone marrow. And so we've totally changed from chronic cyclophosphamide to short-term cyclophosphamide, followed by one of these other medications. And in 2010, we were part of a study led by colleagues from other institutions, Johns Hopkins and Harvard and the Mayo Clinic. We, together with many others, demonstrated that another drug, a new drug, Rituximab, could also induce remissions and spare people the use of cyclophosphamide. So, having been involved in this story now for about 25 years, I've had the privilege of seeing treatment for this disease dramatically change, so that nowadays, although we can't cure the disease, we can control it. So Don, you were among those people who had very severe disease when you first became ill. Was it
1996 it was.
1996. Why don't you share with us what that experience was like in 96 when you first became ill?
Well, actually I experienced it, the first symptoms of it was actually in around February the 16th, was a severe nosebleed, joint pain, and it actually progressively got worse. And I went to a few doctors and they put me some antibiotics saying that I had a sinus infection, and actually that wasn't doing any good. I was getting worse every day. Then it was around February 27th, excuse me, February 27th that I had a high fever of 103 degrees, severe nosebleeds, joint ache, my feet were swollen. And at that time, my wife did call my family physician, and he said, get him into the hospital immediately. And of course, once I was admitted to the hospital, excuse me, they were treating me for actually giving me antibiotics and felt like maybe a severe sinus infection. They weren't sure what it was until my family doctor finally diagnosed it and told them it was Wegener's. Right after that, to determine it was Wegener's, I had an open lung biopsy, and it determined I did have Wegener's. And from that time on, the hospital I was in didn't know how to treat me. And from that point on, my wife was very concerned that they said he doesn't have much time to live. And my family doctor says, bring him to the Cleveland Clinic. And when I got to the Cleveland Clinic, I met you and your staff. And I'm here today, 16 years later, and I feel pretty good for a fellow my age. You've done a great job for me. That's the beginning of Wegener's.
Thanks, Don. And that experience with you was not only incredibly gratifying to be able to take care of you, but to also relive an experience that we've had before. And that is, by the time we saw you, you already had kidney failure, you were already on dialysis, your lung function was not great, and you were able to show us what we had demonstrated in many other people before works over and over again. High-dose steroids, cyclophosphamide. It wasn't too long before you went into remission. And then we went through the dance we usually go through. We step down from cyclophosphamide. We try and maintain with other medications. And sometimes we're able to do that with great success. And sometimes we have to try and try again until we find the right maintenance therapy. Perhaps because you're a real expert on this, having gone through a number of these alternative therapies for maintenance. Why don't you share with us some of the experience that you had with some of these other drugs when we stepped down from cyclophosphamide?
I think I was on quite a few different drugs at that time. Right now I'm on Cellcept, which seems to be working. I take 1,000 milligrams a day. My maintenance level was 5 milligrams of prednisone a day. And I feel pretty good. I feel, for a fellow my age, I feel pretty good. I think the medication I'm on right now really works. I have very few side effects with it, which is important. Prior to that, though, when I was on Cytoxin, I always had a constant heartburn and upset stomach, so I'm glad I'm off of that. And of course, when you're on that, you have to drink a lot of water to flush out your bladder.
You do.
It's very important. You have to do that.
And thanks for mentioning that, too, because still, in this day and age, we still use cyclophosphamide, Cytoxin, and a lot of folks, when they come to us in consultation, are not always knowledgeable enough about how to take cyclophosphamide and also protect your bladder. So the breakdown product of cyclophosphamide, called acrolein, actually produces a chemical burn to the bladder. And that chemical burn if it's allowed to occur over and over and over again, will actually set you up for bladder cancer. And if not bladder cancer, a highly irritated bladder that's very prone to bleeding that we call cystitis. So we have always stressed to patients, if they're going to be on cyclophosphamide because they have very severe disease, we will encourage them to drink a lot in the morning, get that urine really dilute so the cyclophosphamide breakdown products are dilute in the bladder and not as likely to cause a burn, and then to follow up the rest of the day with a lot of fluid so the urine remains quite dilute, and that is, the cyclophosphamide breakdown products remain dilute in the bladder. All too often, we have patients coming to us where they had the right treatment by their local doctors, life-saving treatment with cyclophosphamide and high-dose steroids, but they're not forcing the fluids like you emphasized, critically important. And sometimes they're taking the cyclophosphamide multiple times a day, which is totally unnecessary. Once a day is fine. We like to, if we're going to have to expose the bladder to the cyclophosphamide breakdown products, we only want to see that happen once a day. We don't want to expose the bladder several times a day to that. So it only should be dosed once a day. And nowadays, we are very keen to also use this new drug that we have studied, which works in most people as well as cyclophosphamide, and in some people better, Rituximab. And that doesn't have any of those side effects, performs about as well as cyclophosphamide, although not everybody is really able to tolerate that either. Now, you had an experience with Rituximab also, and what happened?
Well, I had it, and I think it was 2 or 3 days later, I came up with a severe fever. And I think I did end up in the hospital for 2 or 3 days to bring that fever down. I have an allergic reaction to it, so I cannot take it again.
So you're among 1 or 2% of people who actually can take Rituximab, although the great majority can. We don't know yet whether or not Rituximab is going to replace cyclophosphamide. There is perhaps a place for still using one or the other. Unfortunately, we're living in an era when we have lots of options of active medications. So not knowing how any one patient's going to respond, but having a sense overall that we can control this disease with cyclophosphamide, with Rituximab, we can do step-down therapy to methotrexate, azathioprine, Celsep, mycophenolate. It's these choices that have enriched us, because if somebody doesn't tolerate a drug, and that's a very individual, idiosyncratic thing, you know, your last 99 out of 100 patients may have tolerated it, but your next patient may not. So having these choices gives us a lot of options and allows us to tailor therapy to individual patients. So you're a good example of that. We went through a number of medications with you, and fortunately you are in remission. And would you say, even though we're talking about a disease that used to kill within an average of 5 months, that your quality of life, would you say it's pretty good?
Yes, I lead a very normal life. I do a lot. I'm quite physical. I walk every day. I like to work in my yard. I take my medication faithfully every day. I know my disease. I know my body. I know when I'm having a flare-up. And as soon as anything at the last chronic 1 to 2 days, I get to the doctor right away. Dr. Hoffman sees me. If he determines I am having a flare-up, I'm admitted to the hospital. I'm in there for 4 to 5 days, and I'm home again. I think what you have to do with this disease here is have a positive attitude. And I think that's so important. You can defeat anything in life if you think positive. When I was diagnosed with Wegener's, I was bummed out at first. But then I started thinking, I can defeat this disease. And I feel I have in my own mind. I live a normal life. I feel great, thanks to you. And I hope to make another 16 years. Maybe I will.
Well, I'm going to work with you on that.
Thank you.
Yeah.
Do it together.
So we've learned a lot of lessons from your experiences. Number one, in our experience here at the Cleveland Clinic, it's very, very rare to have patients die from this disease. And I don't think it's because we're a lot smarter than anyone else, but we certainly have a lot of experience. Number two, we have a Vasculitis Center, which we're very proud of, and that means that even if I'm out of town, you have 10 other people here who specialize in vasculitis who will back me up. So if I'm gone, you have other go-to people. And they all know that when a vasculitis patient calls, that means come in right now or come in tomorrow. That a totally inappropriate response would be, keep your appointment next week, I'll see you then. Because so much can happen so quickly, as you know, when you first got sick, all of a sudden you're fine and then you're on dialysis. So people have to be very quick in terms of their clinical reflexes to respect the disease, to worry about you, get you in immediately if you have any kind of complaint whatsoever. There can't be delay there. And the other lesson you taught us is you could even be so sick as to be on dialysis. And with aggressive treatment with acute renal failure, 75% of people can come off dialysis and have normal or near normal kidney function. So we always tell people that when the kidneys are gone, they may actually not be gone, they may just be out to lunch. And you've got to be very aggressive in treating that to get people back to high quality of life with dialysis-independent kidney function. But on the other hand, we do have some people who come to us too late and we can't save their kidneys. And for them, transplantation is very, very effective. In fact, patients who are transplanted do even better than people who are not transplanted. And I think that's because the immunosuppressive therapy that they get for their transplant is never stopped lifelong. And so they're always suppressed and they don't come off their medication and they have very rare relapses compared to people who might come off their medication. So it's a new era, and I'm old enough to have gone through all the iterations of the evolution of treatment, and I'm glad that you've been able to take that trip with me.
Thank you.
So thanks for coming in.
Thank you, doctor.
Thanks for being my clinical partner, and thanks for being an educator here today for all the people who will watch our video.
Thank you, doctor.